speaker is Dr. Alicia Chang. We will continue our symposium with her. Alicia completed her medical school at Tulane University before going on to residency at Columbia University Medical Center. Then she completed her fellowship at Baylor College of Medicine in Houston, and she joined our team at Dell Children's as a member leading our sickle cell disease program. Please welcome Dr. Chang today as she speaks to us on anemia.
This one's forward. Oh, okay. All right. Good morning, everyone. Thank you all for taking your Saturday and coming to our first ever Hematology Oncology Symposium. I am excited to talk to you all today about anemia, a diagnostic and management approach for primary care. I have no financial disclosures. So here's the outline of my talk today. So first we will review the definition of anemia, how we recommend working up cases of anemia in the outpatient setting. We will review common presentations of anemia in the form of patient cases with an emphasis on iron deficiency anemia and thalassemia trait. Then we will review some up-to-date evidence-based guidelines on the management of iron deficiency anemia and close with just some considerations of when and who to refer to hematology. So anemia is defined as a reduction in the blood hemoglobin concentration or red blood cell mass less than the 2.5th percentile for age and sex, so 2 standard deviations below the mean, based on reference ranges in healthy children. And there are reports of hemoglobin values of about 0.5 gram to a gram lower in Black Americans. However, we think this likely reflects health disparities, as we know that anemia disproportionately affects minorities, particularly Blacks and Latinos. And so we don't consider this value to necessarily be benign. And we use the same hemoglobin values when evaluating anemia in all race and ethnic groups. So there are, many different reference tables that exist out there that will show you the hemoglobin, the mean and the 2 standard deviations below the mean for hemoglobin, hematocrit, and MCV based on age. This one comes from the Harriet Lane Handbook, and it's important to remember that the reference ranges in the community may differ slightly from some of these tables, especially in the younger ages. On the right here is just my sort of cheat sheet for lower limit of hemoglobin based on age. Of course, a lot less precise than these tables, but just easier to remember and gives you a general reference for what may be a normal or abnormal hemoglobin based on age. So any hemoglobin level lower than 11 from 6 months to 6 years of age, less than 11.5 in 6 years to 12, from 12 years to 18, anything less than 11.5 in girls or 12.5 to 13 in boys, and any hemoglobin less than 11 in pregnancy. So when looking at different causes of anemia, it's important to remember that the etiology will differ based on age. So age really matters. So from birth to 3 months, we have physiologic anemia of infancy. Of course, there's also pathologic anemias that exist in this age group as well. Physiologic anemia of infancy occurs anywhere between 6 weeks to 9 weeks of age in a term baby. It's due to the increase in oxygenation, tissue oxygenation at that age and the resultant decrease in erythropoietin production that we see. In a term baby, this anemia is always mild and asymptomatic with a nadir anywhere between 9.5 to 11 grams per deciliter. Any of the following below would signify a pathologic anemia in this age group. So any extreme anemias in a term baby, hemoglobin less than 13.5 in the first month, less than 9 in the physiologic time frame. Any signs of symptomatic anemia, so in this age group we look for poor feeding, lethargy, poor weight gain, shortness of breath. Signs of hemolysis, so an exaggerated indirect hyperbilirubinemia. Examples of some pathologic anemias in this age group include immune hemolytic disease of the newborn, blood loss, for example, from acute blood loss from a subgaleal hematoma, or some inherited red blood cell disorders that we see, including membranopathies like hereditary spherocytosis, or enzymopathies like G6PD deficiency. Premature babies are their own risk group for anemia, we know, due to their decrease in red blood cell lifespan. They also have a more blunted and exaggerated erythropoietin production due to an immature liver. And so we fully expect a earlier and exaggerated physiologic nadir in this age group, usually proportional to the degree of prematurity of the baby. In this group of babies, they're also at higher risk for iron deficiency, as we know that the bulk of maternal to fetal iron transfer occurs in that third trimester. In toddlers and children, the most common causes of anemia are likely nutritional. And so really, when and who to screen should be based on a good dietary history, based on several national clinical guidelines. We will go over why it's recommended to screen breastfed infants for anemia a little bit sooner than formula-fed infants. And any infant who has any concerning signs and symptoms that you see, right? So pica, eating non-food items like dirt or clay or paper, any delays that you see in the child that would make you concerned about their ability to intake oral iron, so food aversions or sensory issues, or also any delays that might be a result of nutritional deficiencies should be looked into. And caregiver reports of pallor should be recognized and brought attention to, though we find that pallor can correlate actually quite poorly with a mild anemia, but more so with a severe anemia. So in teens and adolescents, of course, yes, common things, anemia can definitely be nutritional as well, but more so likely compounded by losses. So in girls, very important to take a really good menstrual history, really try to quantify that amount of blood loss that's happening per month. And in boys and girls, consider, occult blood losses. For example, through the GI tract, we have a fair number of patients who come to us in this age group who have anemia secondary to chronic inflammation and iron deficiency from blood loss due to a new diagnosis of inflammatory bowel disease. Some inherited causes of anemia can favor certain sexes and ethnicities, so important to consider these factors as well, though of course you wouldn't screen solely based on sex and ethnicity alone. For sex, for example, some X-linked disorders include G6PD deficiency. In girls, we talked a little bit about that menstrual blood loss, and we'll actually have a talk later this morning more in depth about this. Ethnic background can offer some guidance as well. For example, sickle cell disease, G6PD deficiency, highly prevalent in malaria endemic areas. So areas of Africa, South America, parts of India. Thalassemia can be quite common as well in persons of Mediterranean and Southeast Asian descent. So I think the take-home message really is that anemia is not a diagnosis, right? It's a finding that warrants further investigation. So if your practice allows sending a full CBC over a point-of-care hemoglobin can be very valuable. It can offer important indices that can help you sort of drill down on what might be causing that anemia. So the MCV, the mean corpuscular volume, that's the mean volume of the red cell. You can be either microcytic, normocytic, macrocytic. The RDW, the red cell distribution width, is a quantifiable measurement of the variable of size of the red cell. Normal is usually between 12 and 14. And the mean corpuscular hemoglobin concentration, or the MCHC, gives you a value of the grams of hemoglobin per volume of red cell. It's also a calculated index, but can hint towards if the red cell is hypochromic or normochromic. Other cell lines, super important, right, from Dr. Mian's talk as well. Of course, if you have a mild to moderate anemia with other severe cytopenias, that's going to really open your differential quite broadly. It'll probably prompt a call to us sooner rather than later. And you can see things like a reactive thrombocytosis in anemia or iron deficiency anemia as well. So other cell lines are really important. Even better if you could send a reticulocyte count with that CBC, either an absolute or a percentage count, can really give insight onto the bone marrow response relative to that degree of anemia. So can point you towards thinking about a destructive process versus hypoproduction or nutritional deficiency. The retic count can also give you some information on, maybe the phase of illness as well. Is typically the retic count lags at the beginning of an acute illness and then becomes a lot more robust towards the end when the bone marrow starts to recover. And of course, a peripheral smear can give you globally all the morphology of all the cells, which is super valuable. I wouldn't be a hematologist if I didn't force you all to look at some peripheral smears this morning. So this is, your normal, beautiful peripheral smear. Shown here, you have a normochromic, normocytic red cell, normal platelets, normal lymphocyte up there. This is a smear that shows basophilic stippling within the red cell. This can be indicative of lead toxicity. We also see it in some hemoglobinopathies as well. This is a slide from a patient with sickle cell anemia. You can obviously see the degree of anemia. The arrows are pointing to those sickled red cells. We have a nucleated red cell with that, the arrow without the stem, showing sort of hemolysis and ineffective erythropoiesis, and some target cells as well. This slide is showing microcytic hypochromic red cells and abundant target cells that we can see in thalassemia trait. And this is your classic smear that you would see in a patient with iron deficiency anemia. Again, very microcytic hypochromic red cells. There's a lymphocyte there for comparison, some oddly shaped cells, pencil cells, what we call some of those cells as well. And so, there are extensive algorithms that walk you through all the different possible etiologies of anemia that I'm sure you guys have seen. But really, if you have a good physical and history, a CBC, a peripheral smear, and a retic count, you can really drill down pretty nicely on your differential for anemia, and common things being common. Most common causes of microcytic anemia: iron deficiency, thalassemia trait, or lead toxicity. A normocytic anemia, think of acute blood loss, of course. There's immune-mediated etiologies, and chronic inflammation can cause a normocytic anemia. And for a macrocytic anemia, there are some drugs patients are on, longstanding or chronic anti-epileptics. Certain drugs can cause a macrocytic anemia. And nutritional deficiencies other than iron, so B12 or folate, can cause a macrocytic anemia. Just an aside, if you're concerned about B12 or folate deficiency in your patient, please send a methylmalonic acid and a homocysteine level, as those are much more sensitive markers for these deficiencies than a total B12 or a blood folate level. Okay, let's just do a case. So this picture sort of foreshadows this case, but I'm sure it's a very common case you guys have seen. A 22-month-old ex-full term boy presents his PCP. He often eats toilet paper and dirt. And mom says he looks a bit pale, but otherwise he's running around like a crazy man. You take a good feeding history and you find that he's formula fed until 12 months of age, but since then he's probably eaten like a potato chip. And other than that, he just drinks cow's milk all day long because they're really scared that he's going to get hungry. And so you decide to send a CBC and a peripheral smear, and you find that he has a pretty severe microcytic anemia with a high RDW. You also look at his indices. You know that you see his platelets are, he has a mild thrombocytosis. They're slightly high with a normal white count. Your smears here showing microcytic hypochromic red cells and a fair degree of anemia. So, this case, the patient, the labs, the history, all really point to iron deficiency anemia. And so important to know that if you have these findings, it's really reasonable to just start iron right there without any additional testing at all. Just a quick slide on the prevalence of iron deficiency anemia. Globally, most common hematologic condition, leading cause of anemia. In the United States, it's estimated that 3% of children ages 1 to 2 years have iron deficiency anemia, and 10% in that group are just iron deficient alone. There is a bimodal peak, so 5% of adolescent females are thought to be have iron deficiency anemia, and 13% suffer from iron deficiency alone. And we know that kiddos of lower socioeconomic status and racial minority groups are disproportionately affected by iron deficiency anemia. So because we know, the prevalence is so high, the risk factors are so well established, the American Academy of Pediatrics created recommendations for prevention of iron deficiency anemia. These were published in 2010. We actually anticipate more up-to-date guidelines coming out sometime this year. So we know that prematurity affects iron stores. So premature infants fed human milk, and there is some debate that even premature infants who are formula fed may benefit from iron. So the intervention is to start iron 2 mg per kg per day at 2 weeks of life. In a term breastfed infant, we know that maternal iron stores wane in around 4 months of life in baby. And so these babies are at risk for iron deficiency much earlier than formula-fed infants, anywhere from 9 to 12 months of age. So starting iron at a maintenance dose of 1 mg per kg per day at 4 months is what is recommended. And then for toddlers, ages 1 to 3 years, just really limit that cow's milk to less than 16 ounces per day. And introducing iron-rich foods really early can help prevent iron deficiency anemia. For my kids, the first food they ate at 6 months was pureed beef. It's disgusting. Nobody endorses that but me. But it worked because I was a hematologist and I was not going to have iron-deficient children. Okay, so in terms of treatment of iron deficiency anemia, there are many different formulations of iron that exist out there, but ferrous sulfate or iron salts are the most well established. They're the most studied, and so still considered first line. But we know as clinicians that we might just be prescribing what is palatable to the patient. In terms of dosing, clinical trials have shown us that actually less is more. So starting a moderate dose of about 3 mg per kg once daily dosing can actually increase the fractional amount of iron absorbed in the gut and decrease unwanted side effects like nausea and constipation that we see quite commonly with iron, that we see with like twice daily and 3 times daily dosing. So really, once daily dosing is the way to go. We also know that the more iron deficient your patient is, the more iron will be absorbed in the gut. So it's also very reasonable to start at a somewhat higher dosing, and as you replete those iron stores, actually decrease that dose. We also recommend giving iron 2 hours prior or after meals without dairy, so don't put it in your milk. And then vitamin C rich foods can aid in the absorption, so strawberries, oranges, things like that. Pillars in management for severe iron deficiency anemia, in addition to starting ferrous sulfate, would be to address that underlying etiology. So day one, you're talking to the family, no more milk, or limit that milk. It's not going to happen overnight, but it has to start when the diagnosis is made. We recommend close follow-up within 7 to 10 days for a few reasons. One is to just ensure compliance, because iron can be pretty gross. And then you really want to check their labs because you should see some element of reticulocytosis and an increase of hemoglobin of about 1 gram per deciliter just within a week of starting a good dose of iron. Follow-up should be at 1 month, just again to check compliance, make sure everything's going well, and then really a duration of 3 months is what is recommended of iron therapy. So this is just an algorithm of how frequently you should be seeing the patient and how long you should be treating the patient with iron based on severity of the anemia. This comes out of Jackie Power's very nice paper from 2019 that I've cited throughout this talk. And just sort of shows you, of course, if they have a more mild anemia, you could consider seeing them in 3 to 4 weeks, and then but really treating all of these patients for 3 months is what is recommended. Okay, so the Choosing Wisely campaign is an evidence or a quality improvement initiative led by the American Board of Internal Medicine, who partner with national societies in the US to try to improve high-quality, evidence-based care for patients. And so in 2019, the American Society of Pediatric Hematology Oncology, or ASPHO, and the American Society of Hematology, or ASH, came together and published guidelines on 5 high-yield hematology topics under the umbrella of the Choosing Wisely campaign. I just want to highlight here, one of the authors and contributors of this talk was our very own Dr. Jenna Priola, sitting right there. Very proud of her. But one of their key recommendations was they looked at iron deficient patients who are asymptomatic and really, really recommended not transfusing these patients if they were asymptomatic, if there was no evidence of hemodynamic instability or ongoing blood loss. So when to send your patients to the ED? So of course, if they are symptomatic from their anemia, they're at high risk of stroke, they should come in, they should get some blood. So persistent tachycardia, shortness of breath, dizziness, syncope, extreme fatigue, all absolutely warrant having that kid come in. We really recommend, though, to please try to not send your patient to the ED just on a hemoglobin value alone. So usually the case is you see the kid in clinic, they look fairly well, but there are some, something in the history or the physical that make you concerned. You send a CBC, it goes to the community lab, it comes back at like 6 p.m., and let's say that hemoglobin comes back at 5. It's very classic for iron deficiency anemia, and the patient looked well. Do not send that child to the ER, please, please, please. If they're well in the ER, they'll drive 2 hours to the ER, and really if we see them and they look well and it's consistent with what you found, we're just gonna start iron, do some education, and probably send them home. So really, just something to think about. And of course, we are available 24/7 via Medlic. If you get a CBC late at night, you don't know what to do, please call us, we're happy to help. Thank you. When to call us, really anytime. Like I said, we're here to help. Some patients that we would absolutely want to see in our clinic would be patients who the anemia does not improve with iron therapy, complex patients with iron deficiency anemia, so any patients with oral aversion, developmental delay, concerns that you have that there are other processes going on contributing to the anemia, like inflammation or blood loss. We tend to look at some more kind of specialized tests, including a reticulocyte hemoglobin concentration or content that can really show us a sensitive marker of your bone marrow iron stores because your reticulocytes turn over much more frequently. We also look at soluble transferrin receptor, which can help us tease out whether that anemia might be due to iron deficiency or due to inflammation. And then we would love to see any patients who you start on iron, they're not able to tolerate iron, as we're able to give or provide IV iron or parenteral iron in our clinic. Okay, so just one more case to contrast to that past one. So this is a 13-month-old ex-full-term girl presenting to her PCP for her well child check. Mom feels she looks a little pale, but otherwise she's okay, no concerns. You take a feeding history. This child was formula fed until just about a month ago. She now drinks about 12 ounces of cow's milk. She started purees at 5 months, and she's actually eating like a champ. So because of the pallor, you decide to elect to send a CBC, and you find that she does have a mild microcytic anemia, and I'll just put the indices from our other case just so we can compare. You see that there are some differences. The RBC count is high in this patient. The RDW is normal, and the platelet count is normal. But this child does have a mild microcytic anemia. So astutely, because this case doesn't fit into the nice box of iron deficiency, you decide to send some additional labs. You find that the ferritin is actually pretty robust at 36. You send a hemoglobin electrophoresis that shows an elevated hemoglobin A2 and a slightly elevated hemoglobin F. The peripheral smear you sent as well looks like this. So this child has thalassemia trait. So thalassemia is a defect in globin gene production resulting in an imbalance of your alpha and beta globin genes. For beta thal trait, it's the loss or reduced production of 1 beta globin gene, alpha thal trait of 2 alpha globin genes. This is a mild anemia that does not require any treatment at all. It's caused by hundreds of different mutations. And just some take-home points, it's important to recognize that patients can have thalassemia trait and iron deficiency. So you really want to send those iron studies, one, so you know that you're treating the right thing, but two, because if you want to send a hemoglobin electrophoresis, you need replete iron stores for that to be accurate. So just some pearls, send your hemoglobin electrophoresis only after you correct for iron deficiency, if you think that's what's going on, if the patient has a low ferritin. Your hemoglobin electrophoresis can help distinguish beta thal trait, but if your family is concerned about, or you're concerned about alpha thal trait, that would require DNA-based testing. That can be hard to approve with insurance since it won't change your management, but can be really useful for prenatal counseling and things like that. The Metzner index, you may all have learned in your studies somewhere, it's the MCV count over the RBC count, and this tends to favor iron deficiency if your Metzner index is greater than 13. So just some comparisons between iron deficiency anemia and thalassemia trait in terms of indices. It's a little bit nuanced, but hemoglobin, you'll never expect a severe anemia in thalassemia trait if it's thalassemia trait alone. Your RDW can be normal, but it also can be elevated in thalassemia trait. It will often be elevated in iron deficiency anemia. Your ferritin will always be low in iron deficiency anemia and can be or will be normal if you're dealing with thalassemia trait alone. And your hemoglobin electrophoresis will be normal if you are only dealing with iron deficiency anemia and alpha thal trait, it will be normal too. You, again, need that DNA-based testing, but you can see changes consistent with beta thalassemia trait in your hemoglobin electrophoresis. Okay, so just some take-home points from this talk. So a full CBC is preferred over a point-of-care hemoglobin for evaluation of anemia. Once daily dosing of ferrous sulfate is sufficient to treat iron deficiency anemia. And for iron deficiency anemic patients, please only send them to the ED for symptomatic anemia. You know, of course, there might be some complex social situations. You know, it's not this black and white, but really just in general. And if your history or indices do not fully support iron deficiency as a cause of anemia, please send additional studies and consider thalassemia trait or other etiologies of a microcytic anemia. And we are always here to help. And that's it. Thank you so much for your time.